Welcome, everybody. My name is Noah Lipton. I'm an implementation specialist with the Center for Practice Innovations and specifically with NYC TCTTAC, the Tobacco Cessation Training and Technical Assistance Center. And I'm so pleased to see the turnout for this, what Rusty and I both think, and I'm with, I should say, I'm with Rusty Foster as well from TCTTAC, and Nancy Colville is also helping by hosting this forum. We're really excited for this unique opportunity to talk about applying motivational interviewing to treatment planning and to documentation when working with tobacco users in the early stages of change. I know a lot of people, or I'm guessing that a lot of people that have joined have been trained in motivational interviewing, perhaps multiple times, but documentation is not typically something that's a part of those trainings, yet it's something that all of us do in our work. And it's a really important part of our work. So it's important that we also have some strategies, some tools in mind in terms of how do we actually really capture the great work that we're doing and that the participants are doing in their efforts to make changes to their tobacco use, to other things, so that that's captured both for us and being able to review historically, but also for other people that are going to be looking at our treatment plans down the line. I just want to mention a couple of things right at the outset here. So this is not a training on motivational interviewing. We will, of course, be touching on a lot of the aspects of it, but we clearly don't have time to dig into motivational interviewing itself very much. But we'll be touching on a lot of different things, so there'll be some review aspects. It's also not a training on how to get someone to stop smoking. That's, again, not something that we have the time for, and not that we would be getting someone to stop smoking, but really, like, looking at different strategies. But really the focus here is on documentation. So there may be some questions that come up around how might we use certain strategies. We'll see if there's time to address those, but really it's around documentation. I also just want to say that I imagine all of us are from different agencies, from different programs, that all have their own kind of guidance and policies and procedures around documentation. Certainly none of what we're going to be talking about today is meant to supplant that. Really, they're just guidelines or guidance around how you might think about documenting the motivational interviewing techniques and tools and aspects of the spirit, et cetera, that you're using in your day-to-day work. So I'm not going to read this, but very briefly, it's just a disclosure that we're not being financially supported by any of the commercial MDs that might be discussed as we go along. So the learning objectives for today. So we're going to be talking about, and I'll just go ahead and click through here, but really how to document goals and interventions and perhaps objectives as well in treatment plans, in progress notes, even how we use assessments and how we provide feedback after doing assessments with participants for people, particularly in the early stages of change. So that's pre-contemplation, contemplation, and preparation. I should also mention that we haven't yet decided, there's not a date yet determined, but in the future we will also be providing another webinar, live webinar, and this one will be featuring Dr. Jill Williams, talking about how do we do the same, but for the later stages. So for those people that have moved on to action, to relapse prevention, how do we, go about, again, kind of capturing in documentation what it is that we're doing. So you can expect to see kind of an update with more information about that at some point in the future. So the agenda for today. So we have a question about you to kind of get us started about doing this very thing we're going to be talking about today. We're going to talk a little bit about why is this important to even be talking about, why address this. We'll do some review around the stages of change, the 4 processes in motivational interviewing, as well as person-centered treatment planning to kind of anchor the future discussion that we're going to be having, which is, again, really about documenting all these different aspects of motivational interviewing. And Rusty Foster will be taking over at that point. And then we'll be wrapping up at the end. So a question for you, and feel free here to write in the chat box. What would you like to know about treatment planning when using motivational interviewing for people in the early stages of change around their tobacco use? And Nancy, I think it might be helpful if we increase the size of the box. So we're able to see all the responses. So any particular questions or perhaps issues that have come up in doing treatment planning related to documenting motivational interviewing? And I think what we might do is we might speak a little bit to what folks are inputting now and what you're sharing with us. But what we thought we might do is that after we go through the review portion, we'll kind of pause a little bit, take some questions then, and then Rusty will be taking over as we discuss kind of pre-contemplation and moving into more of the documentation piece. So Rich writes some common measurable objectives. Okay, so how are we, in a way, it sounds like Rich kind of measuring people's progress, particularly perhaps, because I think I think really that speaks in a way to, I think at least, one of the main reasons why we thought this might be an important topic to talk about is when someone has not yet decided to make a change in their smoking, perhaps it's not even something that they're considering changing. How do we document that? So what might, an objective be, particularly when one of the things that we want to maintain in the process is being person-centered, right? So if it's not something that the person has articulated, is it really person-centered to include it, and how do we go about that? So that really is, I think, one of the main kind of challenges here, and certainly one of the things that we can talk about. Constance agrees. So she's also looking for common measurable objectives as well as language, and we're going to talk a lot about language today. Maria says that she cannot see the screen, only the speaker. So I'm not sure if we can help her with that, Nancy. Dawn writes how to motivate without sounding oops, whoa. Sorry about that. Okay. Sorry about that close-up. How to motivate without sounding disingenuous. So certainly we'll be talking about that. How to measure reduction in resistance and ambivalence. These are great kind of questions and issues for us to kind of think about as we go along. And okay, and I'm not sure how to pronounce your name. I'm sorry if it's Mame or Mame. Writes that she's also interested in how would we do this work without sounding disingenuous. So these are certainly some of the challenges that I think we probably all have when it comes to doing this kind of documentation, particularly when folks are in the early stages of change. So we'll be speaking to them, and then maybe when we come to that initial break, we can talk a little bit more if we haven't really addressed your questions. Okay, I think we can reduce the box now. Thank you, Nancy. Okay, so thank you for your feedback on that. So why talk about this? So all of us, I'm sure, are required to write treatment plans, to write notes, as it provides a record, of course, of the work that we're doing with people. It also really should serve as kind of a roadmap in a way for the work that we're going to be doing going forward, and kind of creates perhaps some benchmarks that are ultimately going to help people to move toward a goal. But really, as I mentioned earlier, the challenge is how do we do this when folks have not yet identified wanting to make a change, right? How do we make it person-centered? How do we, as some folks mentioned, how can we make that a measurable kind of process? I think this is actually, one of the nice things about motivational interviewing, which is really, a set of strategies and also a kind of overall approach for folks that are ambivalent about change or haven't yet decided to make a change. And there's really myriad ways within motivational interviewing of helping people to kind of think about what it is that the particular behavior. So in this case, we're talking about smoking, what they like about it, what they don't like about it, and really expanding on that ambivalence using the OR strategies, using different ways of evoking change talk. So there's so much within motivational interviewing that even if we're not necessarily even if the person hasn't identified a particular goal, and that's kind of what we're working toward, there's still plenty of things we can do to help engage in a conversation that's going to open up that dialogue. We can't necessarily predict where it's going to lead, nor should we try, but by opening up the dialogue, by opening up the conversation, we're at least kind of finding out more about where the person is, what's working for them, what's not working for them about a particular thing, what are their goals and values, and how does that align with what, a particular behavior, smoking in this case. Is there an area where perhaps we can expand and kind of develop some discrepancy? So there's lots of different things that we can do, even if we're not necessarily focused on that end goal just yet. As I mentioned I think in the agenda, there are a couple of kind of frameworks that I think we should also be thinking about whenever we're doing treatment planning, but also when we're thinking about motivational interviewing. And I think there's a lot of overlap, which are the stages of change, the 4 processes of motivational interviewing, and how do we kind of remain person-centered, throughout this process. Okay, so stages of change. So it's really developed by Prochaska and Di Clemente, who kind of theorized that change is more of a process than an outcome, and kind of came to define it as a sequence of stages, but at the same time, they're not necessarily stages that are linear. It's more circular in that people are likely to go through the stages a number of times before actually being able to sustain a change, or not necessarily circular, but also kind of moving forward and backward. That people may move from, let's say, pre-contemplation to contemplation, and then back to pre-contemplation. Or maybe they start to actually take some active steps. Let's say throw out their cigarettes. Let's say maybe get an NRT prescription, for example. But then decide, I really don't think this is going to work, and they kind of fall back a little bit and perhaps aren't able to kind of follow through on that particular effort to cut down or quit. So, and I think it's important to kind of recognize that and normalize that and see that as part of the change process, not as an effort that failed, so to speak, but as perhaps one more experience that we can kind of call on and look to kind of what can we learn from that? What might be helpful in the future? Similarly, I think we also want to recognize slips as a normal part of the change process, and as well as kind of help preventing, in a way, slips from becoming, I guess, full relapses, we might call it. So how can we help people to kind of bounce back quickly? And I think one of the things that's important is also, throughout this process, remaining positive, persistent, hopeful about change, because I think one of the things that's important, in doing this work in general, but particularly when we're helping people with change, is having hope and communicating that hope. And certainly that can go a long way toward helping people to kind of increase their confidence, their self-efficacy, and being able to make changes. So this kind of captures a little bit the stages of change, particularly in terms of smoking. So pre-contemplation, we might hear something like, I don't want to stop smoking, it helps me relax. Contemplation, sometimes I feel like I smoke too much. I cough when I wake up in the morning, but I feel like I can't stop. Preparation, I'm ready to stop smoking. This is my last pack, and I have an appointment next week with my doctor to get the patch or the gum. Action, I'm not smoking anymore. Whenever I want to smoke, I remind myself of all the good things that can happen when I stop. And finally, maintenance. I haven't had a cigarette for 6 months. I'm using the patch and I've changed my diet. I'm also going to the gym 3 times a week. I'm taking care of my health. I feel so much better. I have more energy and I breathe so much better. My cough has gone away. So you can really see how with each statement it's kind of reflecting a different level of where the person is in the change process, but also their confidence, how much action they've taken to actually make the change. So it really comes across in kind of what we hear people say. Similarly, and I think there's a lot of overlap between these 4 processes of motivational interviewing, which is a more recent addition to kind of the motivational interviewing literature, but an overlap between this and the stages of change, as well as the stages of treatment, actually. So it starts with engagement. Shall we walk together is kind of, in a way, what it is at its essence. So it's really developing that working relationship, kind of coming to that decision that, we're going to be on this journey together, and you're, really just trying to foster that initial working relationship, helping relationship to kind of start this journey together. From there, we're moving on to a really important aspect, which I think sometimes doesn't necessarily get enough attention in motivational interviewing or other aspects of our work, which is focusing. How do we kind of come to those decisions in terms of what are we going to work on together? And really, it should be a very collaborative decision in terms of, what are we going to focus on? What is the priority for right now? I mean, I think there's lots of different factors that we don't have time to get into today, but it's really how are we coming to that decision about what are we going to focus on? And maybe a number of things, but perhaps picking one or two out of, however many things there are. Moving on from there, evoking. So whatever the issues that we've identified and focusing, well, why are we going there? What's important to you about that? How has that gotten in the way, perhaps, of some of the other things that you've wanted to achieve? Or, what do you like about that? In the case of smoking, what do you like about smoking? What are some of the things that you get out of it? So it's really an opportunity to kind of, again, develop that conversation, learn a lot about the person's kind of process and understanding to this point. I think one of the things it speaks to for me is that, when doing motivational interviewing, we're recognizing that there's two experts in the room, right? There's the provider, so we know about motivational interviewing, we know about mental health, perhaps we know about substance use, other techniques or strategies, but the person's really an expert on themselves, right? An expert on what's worked for them, what hasn't, what are they struggling with, what are the things that they enjoy, so it's really important that we kind of recognize that. And finally, planning. How are we going to get to wherever we want to go? And we really, again, want to be collaborative in that process and kind of develop those steps together. So just to say a little bit about kind of person-centeredness, which is certainly the cornerstone of person-centered treatment planning, which is really that the person is at the core of it, right? It really starts from the person's goals. What do they want to work on? What's important to them? Because we know that people are going to be the most motivated and interested in doing things that they identify, that they come up with, not that we're kind of suggesting or deciding, but really what's of interest to them. What do they think are kind of the next, perhaps realistic steps to working toward those goals? So coming back to objectives, so starting with them before perhaps providing some of our own ideas about what those steps might be. And then similarly with interventions and kind of developing those together. Not everything that we could potentially do is going to be amenable to everyone that we're working with. So we're really kind of coming up with those together. And then reevaluating, certainly, as we go along. And these are just a few more aspects to kind of touch on here. So as I was saying, it's certainly collaborative, more of a collaborative process than a prescriptive one. We're really developing the plan together. Strengths-based, which really aligns well with motivational interviewing because the focus on affirmations. So really kind of helping people to kind of either identify strengths, kind of raise consciousness about people's strengths. How have people kind of used those strengths in the past? And really helping that to be part of the narrative, not just what have the barriers been, what have the struggles been, but what have your successes been when you've been able to make a change. However perhaps small the person thinks that it might have been, what helped them to get there, and what perhaps can they harness today to make this current change. And it's incremental, so really allowing the process to kind of take shape over time, not feeling like the person has to kind of make a change very quickly, and in some ways kind of having that put pressure on the process, but really allowing it to be incremental and happen over time. And it's informed by things like recovery. So having it, what is the person's own vision of their recovery? So not just perhaps being about, which is what we used to do, being focused on staying out of the hospital or reducing symptoms, but where does the person actually want to be in their lives? 5 years from now, 3 years from now, where would you like to be, and how might we get there? Being trauma-informed is certainly very important, so recognizing that people have had a range of experiences, before coming to work with us, some of which, might have been quite traumatic. So how can we be sensitive to that, recognizing where there might be vulnerabilities, or where the person might experience, feeling vulnerable. So how can we be sensitive to that, protect against that in our language, in our practices, in where we meet people. I think there's so many ways that we can kind of speak to that and attend to safety, the pace that we're kind of moving in, and checking in about that. Is this too slow? Is this too fast? And certainly, empowering people to make choices about their care, I think, is also important. And being culturally humble or culturally sensitive, is also really important. And kind of approaching all of our work in a way from kind of an asking stance, rather than making assumptions or feeling like, well, this worked for someone, this is going to work for someone else. Really checking in about that and asking about, is this going to work for you? What do you think is going to work for you? What's worked for you in the past? Also, if the person's interested in having their family or other supports be a part of this process, really inviting that and supporting that if that's, an interest of the person. So I don't want to take up, I'm going to go through the next couple of sections more quickly because I know we really want to focus on documentation. But just in summary, what in MI should we document? There's lots of different things, some of which I mentioned earlier, so aspects of the spirit. So how do we communicate that? Readiness for change, and some folks were mentioning about kind of what are some objective measures that we could use. Certainly the importance ruler, the confidence ruler, are really great ways of kind of capturing where someone is at a given time and where they are at a later time. Using the skills, so what are the, what maybe reflections did we offer, or affirmations, or open-ended questions, tools, and what did we learn from them, like the decisional balance, all kinds of different strategies that we don't have time to go over now, and as well as how do we kind of use some of these strategies to help develop a plan. So many different things that we can document. And finally, assessment, which is a really critical part of our work, and again, maybe something that we don't necessarily talk about all that much, or we talk about it at the beginning and then we kind of forget about it. But I think particularly with things like smoking, where we use assessment tools, probably all of us do, to gather information. And actually, maybe before we go on, can we very quickly just bring up a polling question? We'd love to know which assessments, if any of these, do you use for assessing tobacco at your program? And if you use a different tool, please let us know that, and go ahead and write it in the chat box. And I think you're able to choose more than one. So if you use more than one of these, you can let us know that too. So we have a lot of responses coming in. Please continue checking. Looks like the Fagerstrom is popular, the cage as well, and quite a few people use other tools. So let us know what those are. I would guess that some programs or agencies have their own, so perhaps that's what people are using. I'll go ahead and share this information, but thank you for providing that information for us. So we could take that down, but feel free to let us know in the chat box. And I think importantly with assessment is, how are we following that up? What is the conversation that follows in terms of how are we giving feedback, based on what we're learning? And I think there's a way of doing that, certainly from a motivational interviewing style, without judgment, without criticism, remaining neutral, really just providing the information and asking the person what they make of it. And then based on kind of their response to our question, perhaps we could raise some treatment recommendations if it seems like that's appropriate, or if it really seems like the person's not quite there, they're still, pretty ambivalent, or maybe even it's not a concern at all, perhaps there's other ways that we can kind of respond with maybe some open-ended questions around, well, what, or do you have some concerns around your smoking? Or what do you like about it? What are some of the things that you enjoy about it? So, coming back to what I was saying earlier, really just allowing it almost like a way to kind of introduce the topic, perhaps, and engage in some of the different aspects of it without feeling like the need to get to a particular end goal. So sometimes just having the conversation is a great way to start. And as we go along, we're really just documenting each step of the process. So with that, I'm going to pass it to, well, actually at this point, before we go on to Rusty, are there any comments or questions that anyone would like to share at this point? Okay, so with that, I'm going to pass it on to Rusty to talk about pre-contemplation.
Okay, thanks, Noah, and welcome everybody. We've got a very a large group of people, and you know, in the spirit of motivational interviewing, we'll be talking about documentation and then kind of brainstorming using our. There's a lot of brain power in this meeting, and so it's not just going to be me talking, but we're going to try to be as interactive as possible. And what we're going to do, let me just preface this by the whole concept of documenting motivational interviewing. One is, I've done a lot of training, and at the end, people all say, and I never cover documentation, people all say, yes, but how do you document this? And I've never actually covered it. So I felt like, and Noah and I felt like this would be a good webinar to do. And before I did it, I decided to look in the literature for how do you document motivational interviewing. And I found one article. It wasn't an article, it comes out of Santa Clara Valley, California. It's 2008, so it's not new. And it really was around guidance for clinicians in that system. But it had lots of information on stages and motivational interviewing and documenting it. But there's nothing else. There's nothing in the books that Miller and Molnick do. There's nothing in the literature. If you try to find anything, what you get is really somebody. It's like, how do you know if people are proficient at doing motivational interviewing? But there's nothing about documentation. So we're breaking new ground today by going through this. Okay, and what we're going to try to do is look at documentation through three kind of primary elements. One is assessment. 2 is treatment plans, and 3 are progress notes. And if you know of anything else that you would like to see covered, throw it in, and we'll see if we could do it. Okay? And we're going to look through those areas of documentation for each of the 3 early stages of change: pre-contemplation, contemplation, and preparation. And of course, probably the most difficult documentation stage is pre-contemplation, because you're working with somebody in an area where they say they don't have a problem. So how do you document that? And I was thinking about this, we try to be very person-centered, which means, in my mind, when we write something in the document, are we okay by having that person read that? Will they say, I didn't say that, or why did you put that in, or I don't even want to work on this, right? So how could we reflect in a motivational interviewing way what that person really is interested in, and the types of work that we would like to do with that person, okay? So that's kind of the preface to this. So we're going to start with pre-contemplation. And I have to say, we can't be completely inclusive of everything, right? So, because there's so much. So we're going to start, in terms of assessment, with one, and this is, a lot of people use the Fagerstrom, but this is a tool, an assessment tool, and it gives us lots of information about a person smoking, and so we're going to think about that. So we do the assessment, we do the Fagerstrom, and I just came up with this number. but the score is 9, which is really high severity. The highest you can get is 10 when you're doing this. They're like 6 questions. And then one of the things that's important in motivational interviewing around an assessment is you do it and you have a measure. You have a score. And what you want to do is you want to meet with that person and review their score and what it means. You want to give feedback. So we wrote a little thing, and it's review, and it's like what you might write, okay? Because we want to look at what you might document, okay? So we got reviewed results, and of course, write or reviewed results, however you do it. And this is another issue. There's a lot of people on the call from a lot of different agencies, and people do their own documentation. They're unique. A lot of them are unique to the agency, their documentation package. So we're going to try to figure out how this would look in your documentation package. What do you think? How would you do this? That's the question at the end of this. So what I would write, this is what I wrote, okay? I'm writing in the document, okay? I do the assessment, I get the score, and I say, I gave the feedback, and I write, reviewed results with the consumer, ask the person what they know about the risk of smoking, right? What do they know? And then get the information, and then ask permission if I can give additional information. This is a motivational interviewing approach, and this is, we're documenting a motivational interviewing approach, and then the consumer in this instance gives permission. Yes, you could tell me other stuff. So I provide the information, right? And that for people who want to know what it is and what tool the motivational interviewing is, it's called the provide elicit method of giving information. Find out what a person knows, ask permission to give them additional information, give them additional information, and then there's a question at the end that we'll talk about. So we provide information, and then at the end you say, what do you make of all this? What do you think about this? That you got, you got a high, you got a score that says, you got a pretty severe dependency on tobacco, and one of the things we know about that is that there's a lot of health risk associated with that. So what do you make of it, right? And the consumer being in pre-contemplation, and by the way, the assessment helps you decide, helps you identify what stage they're in. But we're talking about somebody's pre-contemplation, and they respond by saying, I don't think smoking is a problem for me. Okay? Now, when they say that, that's what they are. That's where they're at. And we don't want to confront them. This is an assessment process with some feedback. We're not confronting them. So if this is we're using this methodology, we're doing the assessment, we're giving feedback, we're writing this little piece about what happened, what we did, how the consumer responded, how we responded, where would you put this in your documentation? Where would this go? In your assessment documentation, where would you put it? And then the other piece is, where would you put it? And if you wanted to add, is there anything you would change about this that you would add or subtract? Okay? Remember, we're brainstorming. We're thinking together on this. When we finish this, we'll probably have to publish it because no one's ever done this before. Okay, so you would put, Diane Brewer said she would put this information in the treatment plan. Okay. And Nancy, could you expand this? Because sometimes when a lot of people, could you expand the chat box? Excellent. Okay. Okay, where are we now? Consumer. in the progress note and in the in the omission note, you could see no one's really wrong in this. You omission note, treatment plan, progress note, client note for the session, progress note, and then the update summary of the treatment plan, monthly note. You could see it reflects a lot of the way agencies differ in their in how their documentation is set up. But for me, I don't think there's a section in the assessment where you could put this. So I tend to think about putting this in the progress note. But we wanna have a way of documenting in a motivational interview way. And you don't, by the way, you don't have to say, I use the provide illicit method. Your provide illicit method is shown in the actual exchange that you had with the person, okay? So progress note, monthly sums, okay. So is there anything, do you mean what section of the chart would it be put in? I would think it would go in the evaluation section. Now, Suzanne, I think are you from a state facility, a state clinic? Progress note, treatment plan, progress note, monthly progress note. All right. Let me ask you a question. Is this making sense in how we're approaching this, though? You do the assessment. One thing about assessment, and I worked for a long time. I did assessments, treatment plans, etc. And we did assessments, and we never went back to the person and said, look, this is what your assessment showed. And, I was talking to Noah, and it's not just in mental health that happens. And if you go to your primary care doctor, a lot of times you have assessments done, and you don't really get the feedback very well. But I have a primary care doctor. When I see him, I get a written report back that gives me the results, and he mails it to me. I'm like shocked. And I love the guy because it's like he's seeing me as somebody who deserves that information, who could understand that information, who wants that information. So that's how we have to view what we're doing with our consumers, okay? So it goes in a lot of different places depending on your agency's documentation forms, but a lot of people put in the progress note, and that's kind of where I think it should go. And I think that when we're working with people in pre-contemplation, which is meaning that the person is saying, I don't have a problem with this, okay? Now, they could be saying it for a lot of different reasons. I'm being forced to come, I don't have a problem with this. Or I like doing it. Or I tried to change it before and I can't, I give up, right? So they're not interested in this as something they're going to work on. A lot of the information that we do, the interchange we have with them goes best in a progress note, okay? With the assessment, it has to do with giving feedback on the form, but the resulting conversation might go in a progress note. Okay, and then I can't read all these, but psychological evaluations, I set up a feedback session, excellent. Sometimes I put it in the health assessment, okay. And remember, the focus of this documentation is around documenting tobacco use, okay. So, all right, so that's the assessment. Now, the next step would be the treatment plan. So here's a couple steps you could do in a motivational way around smoking. And we're talking about smoking with somebody who doesn't really see that they have a problem. Okay. Now, I put this in. It says raise the issue of smoking, but I think before I always say this, but I didn't do it this time for some reason. But you want to say, tell me what it is about smoking you like. Okay. You always start with that, right? What is it that you like? What do you get out of it? And then, what concerns do you have about smoking? Right. That's the second question. Right. And you're trying to see, is there anything about smoking that's a problem for them? Somebody in pre-contemplation might say, hey, I like smoking. I'm not worried about it. Okay? And you don't want to get into, this is a motivational interviewing approach. You don't want to get into an argument with them. So instead of like trying to say, oh no, you got to work on this, you got to, this is a problem, you shift focus. And anyone who's been trained in motivational interviewing probably has heard about shifting focus, know how to do it. So you ask, well, what would you like to work on? Okay? I can see you don't want to work on smoking, so what would you like to work on? Then they're going to say, I want to do something. And in the way I wrote it, it's they want to go back to work. They want to get a job. That's their goal. That's what's important to them. Okay? Now, what you can do around smoking for a pre-contemplator that they might see is an issue, you could say, well, we're going to work on that, but what impact do you see smoking might have on going back to work? What impact on this goal that's very important to you? Now, whatever they say, you can document, not under the goal, because there's no pre-contemplation. They don't have a goal for cutting back on their smoking. So if you can't list it as a goal, right? Now there's a couple caveats to that, but you can't list it as a goal. But if they say that it might get in the way of working because I have to smoke a lot, right? Then you can list it under barriers. And when you list it under barriers, it could become part of the action plan. But it's not an action to cut back on your smoking. It's an action to be able to work, okay, to remove that barrier. Now, Carrie said it can be listed as a deferred goal. Yes, you could do that. You could say, all right, we're not going to work on that. We're going to defer it for the time being. I thought maybe we could try to do this, but if it works better for you to defer it and then raise it later, and the question is, when would you raise it? Would it be deferred indefinitely, or is there a point where you would decide, would you wait until they go to work and they have problems at work and then maybe revisit it? So those are all questions. So here's what the treatment plan would look like. The goal, this person's goal is to get a job. They have strengths. They're self-reliant, and they might have many other strengths. The barrier that they spoke about is that they need to smoke frequently at work. And that's going to be a problem for them. So the steps to doing this is ask the person what barriers can get in the way of getting a job and working on the job. If they don't mention smoking, you can raise it. This is how you can raise smoking, right? How might smoking affect your ability to get and work on the job, right? And if they say they have to smoke a lot during the day, you can list it as a barrier, and you could even with permission say, while you're at work, one of the things that can help is we can give you the patch. We're not saying you have to quit smoking. This has nothing to do with quit smoking. It has to do with working. And we could give you the patch that you could use, okay? So you explain the reason for deferring the client state. It can be addressed in treatment sessions. Okay. So if you did it deferred, so it's not on the treatment plan, but you're going to address it in treatment sessions, you would write it in the progress note? Well, what would? Now, are there any other questions about how you might do this? And how it would look in your treatment plan. So the treatment plan, the goal would be to get a job. Do people have a section of your treatment plan that talks about barriers? Yes. Yes. Okay. So you'd say the goal is to get a job. Some of the barriers are they smoke frequently, which is going to make them make it hard for them at work. And the steps would include all the steps they're going to do to get a job, and then it'll include an action step around having to figure out how to have less frequent smoking on the job, okay? And that might include using the patch. Does this make sense to people? You could say, no, I'm not, I won't take it personally. Or maybe I would, but I'll. Yes, okay. All right, so what we're trying to do is when we're working with people that say don't have a problem with something, is there some other way that we can visit it? It might not be, right? We might not be able to visit at this point, and I think, I forget who raised that, but the idea of deferring the goal, it might not be something that we can put in the treatment plan at this point. But here, you might, and you might if you take this kind of, it's a motivational interviewing approach with people, right? We're not trying to get you to quit. We want you, though, to be able to achieve the goal that you had for yourself is to getting a job and keeping that job, right? And we know that you're saying that you smoke a lot, and which means you're going to have to take a lot of smoke breaks on the job, and that could really interfere with you keeping your job. So you can ask them, what would be a couple things you could do that might help reduce the number of smoke breaks you have to take, right? Cigarettes are so expensive, usually you can find some impact on life that can be addressed. Right. Right. There are these other tools that they can figure out how much they're spending on cigarettes, and that might, I'm not saying this is the thing. There are a lot of ways to go about doing this. I'm giving you one idea on what you could do and how you can document in the treatment plan. But, there are many, many tools that you could use, like calculating how much you're spending on your smoking. And we have somebody that says, working on the exact problem. He didn't use the patch. Okay, so this is somebody in their treatment plan that had this problem. And what would you consider? I'm having trouble seeing the name. Let's see. Could you expand this, Nance? Okay. Makes a lot of sense. And just a few months ago, I had a client. Okay, so this is Matt. I provide vocational rehab service, and just a few months ago, I had a client who was working on this exact problem. He didn't use the patch, but he did work on limiting his tobacco use to designated break times. One thing he did was to only bring a few cigarettes to work. And Matt, would you consider him somebody who wasn't interested in stopping smoking? Because this is motivational interviewing in action. You know what I'm saying? You're not saying to somebody, hey, you got to stop smoking, okay? It's bad for your health. It's bad for this. You're going to, like, die early. What you're saying is, and what they're saying is, I want to go to work, and I'm willing to do things that will help me stay on the job. So I'm going to smoke less. This is like an incredible thing. And I want to bring, and he had his own idea. This is, people are so smart about this. I'm only going to bring a few cigarettes to work. Because if he brings a pack, he probably end up smoking the pack. So, okay. Constance said, I was speaking to someone yesterday doing CARES and using this approach, and she was in pre-contemplation and did not want to quit, but totally accepted the patch. I was quite surprised. And the reason is, I'm not saying that's the reason she did it, but when I read this, I'm thinking, well, why would she accept the patch? Well, the patches would be helpful, but there's nothing in your approach that said you had to quit smoking. If you got to quit smoking, use the patch. It had to do with her being able to do something else, I assume, that she wanted to do. Right? Sometimes people will approach, look it's weird out there now. There's a lot of smoke-free environments. You go to a restaurant, you can't smoke. You go to the movies, you can't smoke. Because you're smoking and you're not able to smoke, you start feeling withdrawal symptoms and you're going to run out and try to have a cigarette. So if you wanted to stay to see the whole movie, we can give you a patch during that time. You'll get the nicotine you need, and then you can watch the movie, right? But eventually what happens is when people use the patch, sometimes they quit, right? Or sometimes they really cut back. All right. Hey, you look at this. Look at all this stuff. And Kenneth said, eliciting discrepancy to patient's goal and suggestion solution could be helpful. And that is exactly eliciting discrepancy. So smoking a lot, going to work. Going to work is something really important, but the discrepancy is if you keep the smoking the rate you are, you're not going to be able to do the job. And when people see something that's important for them, they're sometimes willing to stop something that's hard to stop. What about the client that stopped smoking cigarettes but is now vaping every 2 hours? Vaping. Carmen, could we come back to that? Do you mind if we come back to that? Because vaping is a tough thing because there's a lot of places that are smoke-free that don't allow vaping either. And there's a lot of... my son has a friend, and he's vaping, and I said, oh, man, he has to vape that often because my son was saying he's vaping a lot. And he must really have been smoking a lot of cigarettes. And my son said, oh, no, he didn't smoke any cigarettes. So he's vaping to get the nicotine. So, all right, I don't want to get into a big vaping conversation, but let's come back to that. Can we let's go back. We got to do progress notes. We only have a few minutes left, and we got to get through some more. Okay, so if you wanted to put this in the progress notes, you can document in the progress notes more detail about the MI strategy used during the assessment and treatment planning process. So you could talk a little bit more about this is what we did. You don't really have to get too much into saying we used to, elicit, provide, elicit, but you could give more detail in the progress notes. You could document the efforts you made in developing the collaborative relationship. None of this works unless you're working together on this. Unless you have engagement, you engage the person, and you have a collaborative relationship. You could document how did you raise the topic? What did you say? How did you raise the topic of smoking? And what is the consumer's interest in changing tobacco? And you could put that whole conversation that you had in the assessment in the progress note. Okay, so we're gonna go on. The progress note is probably the easiest place to put information about somebody who doesn't want to change a behavior, right? Because it's really, you're going to know the kind of conversation you had. But you're not going to put in there something around what you want to do to get them to stop. Because if they read that, and they should have the ability to read their own plans, if they read your progress note and they see that, they're going to see that you're trying to get them to stop. And that's going to be a problem for them. Okay. So this is the progress note that I wrote, okay? You might write better progress notes, maybe shorter ones. Raise possible risk if it continues to smoke. We did that. Consumer stated, I have no interest in quitting. Documented that you shifted focus. This does not seem to be the right time for you to think about changing your... This is what you say. So you could say, writer said, right? Writer said, this does not seem to be the right time for you to think about changing your smoking. What would you like to work on? Consumer responded, I would like to get a job. You don't have to be specific about the MI strategy you use in discussing steps to getting a job. Ask consumer how smoking might impact on the goal. Consumer reported need to smoke frequently, right? So this is like a progress note. It's like a little bit of the process that happened in the conversation. All right, we got to get to contemplation. Now, contemplation, now it's getting a little easier to document treatment plans, right? Because you're working with people that are moving towards developing a plan of change, right? And they're still not ready because they're in contemplation. There's a lot of mixed feelings, okay? So now we're going to do it's the same Fagerstrom, same score, but this is what we're going to do with a person that would be in contemplation. And we're going to know they're in contemplation because of the answers they give to the question we have about what they thought about the score. So you review the results, you ask permission to discuss risk, consumer gives you permission, you also ask permission to give advice, and then you say you might want to consider treatment options like the patch, but it's up to you. You ask the person what they make of it, of all the stuff that you went through. A consumer responded that they would like to stop smoking, but feels that they need to smoke to relax. That's a lot of information to get, right? That's a lot of information, okay? When you get into the plan now, because they want to stop, you could say the goal is to reduce their tobacco use. It doesn't say quit. It just says reduce their tobacco use. They have strengths, and the barrier now is smoking, and the barrier to this goal is smoking helps them relax. And some things that you can do in terms of interventions that you might want to document is you could use the decisional balance to explore their mixed feelings about stopping, not stopping and stopping. You can explore past successes, build their self-efficacy about making the change. You can elicit the person's ideas for alternatives to relaxing, to remove the barrier. You can give more information on health and other consequences. And you can think about having them attend a learning about healthy living group. Okay? So those might be part of the treatment plan action steps. Is there any other, well, we're definitely going to run out of time here. Are there any, how would you write a measurable objective for this goal? Okay, so you want to have a SMART goal, I take it, Julie, right? So you want to say, well, what would be the specific goal? I want to reduce my tobacco use. How would that be measured? And then you could say, I want to reduce my tobacco use by. Give me a number. How many cigarettes did they buy? In half? 10 cigarettes? What would it be? Anybody? You could yell it out. 5. I want to reduce my tobacco use by 5 cigarettes a day. Okay? And then you would say, how are you going to know you did that? How are you going to know that you did that? Well, I'll have a pack of cigarettes, and I should have 15 at the end of the day. You're going to count the cigarettes left in your pack. That could be one way. So you're going to measure it. Is this achievable? Is this something that the person can do? Yes. Okay. Is it relevant to them? Yes. And is it time frame? Okay. So those are SMART goals, right? So you're writing SMART goals. You could write SMART objectives if you want. So you want to make this not generalized to reduce you to tobacco use, but specific. Okay. And you're going to use a decisional balance to explore mixed feelings. Okay. So you're going to use a decisional balance. You're going to use the form. You're going to the consumer and the provider are going to work together, do a decisional balance within the next week, and to help explore. You're going to look at past successes with right. So you could add. Okay. Oh, that Nancy put that. Okay, excellent. Listen, we're out of time. These are like complicated things. You're going to get two things. You're going to get the slides, and you're going to get a sheet that's going to have on one side the stage of change, and on the other side, motivational interviewing interventions that would be helpful in that state of change.
Rusty, I'm sorry, I don't see the sheet to download, so we'll have to follow up, I guess, with an email.
Oh. Okay. Sorry about that. Okay, we'll follow up an email. And take a look at the rest. The preparation isn't designed like this to where you see the treatment plan, because preparation is actually steps to developing a plan, right? Because when you get to preparation, you're now ready to change, and the intervention is the things that you're going to do are the steps you're going to take to develop a treatment plan. Okay, a treatment plan for a completely, say, reducing or quitting your tobacco use. And
I just uploaded the second file, sorry.
Okay, very good. And this is how you write, this is like what a progress note could read. Okay, when I wrote progress notes, progress notes are real art to do, because you want to be inclusive of information that are important, but you don't want to write 15 pages. And I used to write, my hand would hurt sometimes at the end. So, but this is an example of a progress note that you can write and what to document around people in contemplation. We got to stop. We're really running over. I feel at some point we should do documentation, the sequel. So, because there's more we can do. We could set up a little scenario, and then people could write in what they would document. What would the treatment plan sound like? We could really practice. So, all right. Listen, I want to thank everybody for being involved. I knew this was going to be an active group, and continue doing your motivational interviewing work. It's a very helpful.